we're all aware that MindAct was supposed to be presented at San Antonio. And I think we're all a little bit disappointed about that. And my understanding, and I'm curious to hear what other people think about that, my understanding of MindAct was that they just didn't have enough events.
They didn't.
You know, the patients did too well, I guess.
So now the question is it going to be presented at EBCC or ASCO,
yes,
right?
EBCC.
It must have been decided. So.
It must have been decided. So the thing is that, will that change the way we think about things? So clearly, I mean, we all knew this was going to, I mean, a lot of us kind of said, what's new about this when it got published, right? I mean, we all kind of took these pages for granted, as you said, Christy. But the issue is, does it do anything differently for the way we use Oncotype DX?
Well, I think it does, because there are still many people through this country who will not consider doing the recurrence score on a very young patient.
Really?
Or high-grade patient. So what was presented in a poster, actually, by Steve Shack, who's a medical director
of Genomic Health.
Genomic Health.
That's fine.
Was this very fascinating study of over 40,000 women who had Oncotype scores and were matched to SEER. And so they have all the SEER mortality data and whether patients got chemotherapy or not, and they have their Oncotype scores, and they went to a third-party vendor to match the patients. And they have
they were able to do that?
Yes.
I thought SEER's anonymized. It's not anonymized?
Apparently now this is now allowed to occur from the National Cancer Institute, allowed this to occur. A third party has now matched over 40,000 patients. And the outcomes of this are very, very fascinating. However, what was more interesting to me is that in California, for patients who are lymph node negative between the ages of 50 and 60, who have ER-positive cancers, the use of Oncotype is under 50%.
Really?
Yes. So across the country, the best state was New Mexico, who knows why, but it was like 55%. The underuse of Oncotype to me was shocking across this country. And so you don't know what people's motivations are for ordering it or not ordering it. You know, maybe in a very old population, you would consider not ordering it because you're not going to give chemotherapy. But I think I'm not sure people are using this.
But the question is, I think that there are patients for whom I'm not going to give them chemotherapy. So, they have a grade 1 ERPR 100%, 1 centimeter tumor, 0.8 or 1.2. And I see Oncotype being sent a lot of times in those patients when I don't really care if they have a score of 24. I'm not going to give them chemotherapy. So it may be, when I saw that data, I agree, it was surprising. But I think that there may be more to it than you can unearth from this particular data set, which is an interesting question.
So we have two issues here then. We have, are we even going to use the existing Oncotype? But assume MindAct comes out, and the way MindAct is designed, from my understanding of it, is that women are randomized in a group to either have a discordant mammoprint, 70 gene score versus clinical score. This clinical score is based kind of on adjuvant online. And if they're discordant, they're randomized to no chemo or chemo, endocrine therapy alone or endocrine
They're
chemotherapy.
randomized to using either mammoprint result or the clinical pathologic score.
Correct.
So if, for example, you were randomized to mammoprint and you were low risk, you wouldn't get chemo. If you were randomized to mammoprint, you were high risk, you would get chemo, regardless of the clinical pathologic data.
Right.
So, and it includes, a third of the patients have node-positive disease or so.
And about 10% are HER2 positive.
Yeah,
actually,
so it's going to be fascinating.
It is, and the idea behind that is that if you're low-risk mammoprint and you get hormone therapy alone, I think they project your 5-year DFS, disease-free survival, to be like 92%. I think that's the number they're shooting for with their statistics. So really fascinating. I mean, will you guys change what you do if MindAct turns out to be positive in that way?
Positive meaning?
Meaning that if you're low-risk mammoprint, either you're node
doesn't
positive,
matter what your
doesn't matter,
cancer
node positive,
shows.
5 centimeter, getting back to what you're saying, 5 centimeter tumor, node positive, maybe T1C, triple positive, ER positive, HER2 positive. Would you switch then to using the Agendia test?
Well, only if it shows a benefit from chemotherapy. I mean, that's the purpose. They're being randomized to chemotherapy or no chemotherapy.
Right.
So
No, you're treated based, I think, on your score, right?
You wouldn't have chemo if you were low risk.
If you're low risk,
you're
you wouldn't
not
have chemo. If you're
randomized.
high risk, you would.
You're randomized to either being treated based on mammoprint or clinical pathologic treatment if you're
And the
discordant.
assumption is that
How about
everybody.
you,
It may
Joyce?
be a little challenging interpretation of MindAct.
I think that's the point. The devil's going to be in the
think it's a little
details of this.
challenging.
I agree with you. I think
yeah.
the devil's really going to be in the details.
But I do think it will help. I think I've been waiting for that prospective data in a randomized fashion, even though
Right.
the randomization is a bit unconventional.
Right.
Yes, I think if they really show that if you have a low mamma print, even if the adjuvant online is high risk and you're discordant and you come out that you do very, very well with just endocrine therapy alone, I think that will be very important food for thought. It'll be another sort of bulb on the Christmas tree. It's not going to be just one thing
on the
you do.
Christmas
It's going
tree.
to change all
This
of
is the holiday-
practice.
what's the holiday season?
It's just another another thing that in the picture there. I
The
think.
concern is the other group to me. What if they have a high mamma print score and low clinical score? And that group, may actually do well, because to me, high mamma print score is too inclusive. I think there's
Yeah.
too many, it's too broad of a prognostic group from my point of view, because it was really validated in untreated patients. So, it'll be interesting to see in patients who get an endocrine therapy because they're ER positive and don't get chemotherapy because of good clinical features. I think that group will be interesting, but again, the details of this.
We actually presented a little poster at San Antonio. We looked at patients in a couple of U.S. oncology groups and then at UCSF who'd had both MammaPrint and Oncotype. And we looked just at the node-negative group. And the tests are not very concordant, which is fascinating. And of course, the intermediate risk complicates it. But if you use the Taylor-X definition, the low risks are really concordant. And the high risks are really concordant, and the rest is just a complete mess. So it's an interesting question. I mean, you have a patient who has a 14-centimeter lobular cancer and 3 positive nodes and has an Oncotype score of 2. What do you do with that patient?
Well,
You give
and
them
that-
hormone therapy and they relapse.
But they may have relapsed anyway, and that gets us to what I